disability is 10 years behind gender. So by the time we are meeting, we are accomplishing gender equality, then we will need 10 more years to ensure we are accomplishing issues around disability.
And gender equality is like 250 years.
Yeah.
To more.
So that's a lot of time. That's a lot of time. So as we talk about women, we have women with disability. We have girls with disability. So where do we leave them?
Welcome to Equal Footing, a podcast from Usawa Collective where we dive headfirst into the world of gender equality.
We're your hosts,
Madhuri
and Karen, friends and total gender nerds on a mission to uncover the amazing things happening in the space of gender equality around us. We'll be uncovering the challenges, why they exist, but more importantly, we'll be shining a spotlight on the innovators, the change makers, and the game changers who are creating, implementing, and championing solutions.
Think of it as a weekly dose of hope and inspiration, with a side of insightful conversations and maybe even a few laughs along the way. Welcome to Equal Footing, the podcast where we delve into pressing gender equality issues and spotlight innovative solutions in the global south. I'm your co-host, Madhuri, and today we'll be exploring intersectionalities in sexual and reproductive health.
Welcome, and I am Karen Mwanzia, your co-host. Today we have the pleasure of hosting Dorcas Nyasani with us. We'll call her Nyasani for the rest of the show. But from what I've seen, she's a really passionate gender equality and disability inclusion expert who's been working in the development space for quite a number of years now. So I'll not share all the details and speak about her, as people need to introduce themselves. So I'll say welcome, Nyasani. We're quite excited to have you. And looking forward to the conversation.
Thank you for having me.
Well, so maybe let's just start with, tell us about your backstory, Nyasani. I mean, not every day does one wake up as a 10-year-old child thinking that they want to become a sexual health expert. Talk to us about your journey. What inspired you to do the work that you do, and what brought you here?
Oh, thank you so much for having me today. So my name is Dorcas, and I would say I come from a family of medics. So growing up, I knew definitely as the first girl, definitely either a nurse or a doctor. So that was always there. So until I think while I was in high school, when we moved from the coast and moved to Narok. So Narok is predominantly Maasai community, and it has very, very heavy culture. So that was the first time I was interacting with a lot of culture, a community that is very passionate about what they do, their way of life. And it was the first time my parents were getting to become sort of philanthropists as a way. So we got to do a lot of community work. There was a project back then that was led by USAID, Afya Plus, and it was more of an OVC project, and we'll go to the deepest communities to either give out shoes or, community work. So the passion started there, and after high school, I was enrolled in campus, but my dad also enrolled me into a medical college. So I told him, no, what? Let me just go into campus, and then because I didn't want to start at diploma level. So he chose a medical course, psychology. Then when I went to campus, I chose a different course. So I decided to choose a course in community development because I felt that was where the passion was. So in campus, I did a lot of volunteer work. So I wouldn't enjoy my long holidays. Instead of going to, stay at home, I'll go and do a lot of volunteer work. So I joined campus really, really early, before I was 18. So I during the long holidays, I got to do a lot of volunteer work. I started working at 19 as a data clerk in USAID. So, I got to interact a lot with them. And in campus, there was a unit, I did a few units on gender. And that's what I said, I need to do a lot on this. And reflecting on the specific Maasai communities that I was in, women didn't have a lot of rights to enjoy. And I remember one particular time I went to the field and it was a community dialogue meeting. And there were seats, but we were told as women, you have to sit down because seats are reserved for men.
Wow.
And for me, I was like, no, what do you mean? I mean, I come from a family where we are very vocal, where we are 4 girls and 1 boy. So my brother has literally no say in the house. So, so remember when we were having conversations around inheritance, and my dad looked him into the eye and told him, young man, you don't work hard, don't expect me to give you land because everyone in this family is entitled to own land.
Yeah.
So from that perspective, I was like, what do you mean we have to sit down?
Yeah.
No, I want to sit on a seat. So I sat on a seat and everybody was like, she's rude. She should not come back again. But for me, I felt that was a point where we started challenging the norms. You know, you cannot address women as children. So that grew me up. And then I transitioned into now the real development space. And I got to, not immediately, I didn't start gender work immediately. I got into the HIV world and I was like, no, I don't belong here. So I resigned. I stayed at home for like a year. And then I went back, and then now I got into gender work with care.
Mm-hmm.
And I would say the passion really, really grew there. Yeah. So yeah, that's a short story of how I began and how I am here. Yes.
That's interesting.
Mm-hmm.
I'm quite curious. I'll take you back on your journey. The unit you did in your undergrad on gender, what was that? What was in it that sparked that, curiosity that also allowed you to relate the theory often taught in class back to what you are seeing in your community with the Maasai community? And
so we did do a lot of gender work theories, the evolvement. So looking at how gender evolved from the time where it was just the term, from the time it was just looking at women specifically and moving into where they're now concentrating on gender work. And the reasons why people should integrate gender. So we had a lot of units around that. We had a lot of units around GBV. We had a lot of units around norms. So that really sparked the passion. And originally, I also come from a community where girls are not regarded as people, I would say, because even looking at my extended family, my grandfather was very passionate about girl child education. And in my community, we practice FGM. So I don't know if it's something he said, but we always hear people saying, because in our village, I'll say, we are the only family that didn't undergo FGM.
Yeah.
So, and people kind of treat us as outcasts.
Yeah.
So, and people, my grandmother always says, no, your grandfather used to say nobody should be undergo the cut.
Yeah.
So it's something that I feel started way back from the family and the passion. And he didn't have girls. He only had sons. So I think, and most of his grandchildren were girls. So I think he wanted to protect or enjoy having girls around him. Yeah. Yeah.
Yeah. I think like what you're also saying like makes me think that, the experiences of women, they're both universal, but also so different based on, like you mentioned, your community, your tribe. Obviously, just within Kenya, as you move from the coast to Narok to Nairobi, you've had sort of like the good fortune and the privilege of working with international organizations, what that means. So could you maybe talk a little bit about, what is this idea of intersectionality and, how do you see its effects play out in the space of sexual reproductive health, right? Like, how are women from different walks of life impacted differently?
So from my own definition, more I would say intersectionality is a framework that helps us, be able to identify the social identities, like the ones you have mentioned, gender, race, age, the socioeconomic factors, how they interact with the different experiences of men and women. So I'll give an example. I'm almost 30. I'll be turning 30 this year. And from my own side, I know there's a 29-year-old somewhere in, let's say, Marsabit, same age. She's probably married with 3 children, has no education. She depends on the husband. And then there's me. We are the same age. We are both women. I am employed. I have an income. I don't depend on anyone. So our experiences are totally different, because if we were to program, I'll probably not need the need, should probably have the need. So basically, intersectionality helps us identify the specific needs and helps us also respond to those specific needs. Everyone has a unique journey, everyone has a unique characteristic. So we wouldn't want to respond to needs as a whole, because women are not homogeneous. We are different categories, and I like using an example of disability and HIV. So in my line of work, I have always responded to SRH needs for adolescent girls and women. But as we treat them also, we treat them totally different, because you find a 15-year-old who's a dropout. She has 2 kids. She has a disability. She's probably HIV positive. And there's another 15-year-old who's a dropout, has no child, has no disability, probably works a little bit just to earn a living. So the way we'll respond to these 2 adolescents are totally different, because the one with disability will probably need either we have reasonable accommodation in place, or we take the sessions to where they are. We also try to respond to the needs of the child. We also ensure she's on treatment, while the other one can walk to where the sessions are. We wouldn't need a lot to put in place for the one without disability to come. So that's how intersectionality plays along. Yeah.
That's quite interesting. And to go a bit deeper on one of the things you've said. So on this podcast before, we've talked about women not being a homogeneous group, not being a monolith. There's different segments of it. And now we've just talked about a specific segment, which is women with disabilities as well. And I know within disabilities, like there's a whole different types of disabilities. So from your context, especially in the space you work in, this is SRH space, sexual and reproductive health space, how do you see the different groups of disabilities face different barriers? How do they manifest? How do they access services differently even within that? And the reason I ask this question is, personally, as someone who's worked in this gender space for a while, I haven't really gone to even look at this group of women with disabilities. And within that, I also haven't even ever considered, to a great degree, how different disabilities also, like the groups within the groups, and how barriers look different without that. And I think it's something that would be interesting for myself and the audience to know. So if you could unpack a bit of what that world looks like.
All right. So when we talk about disability, we look at the different types, and it's sad to say that most of us concentrate on the physical disability. So when when I walked into this building, the first thing at the entrance, I looked, is there a ramp? Because I'll expect a person on a wheelchair not to be able to use the stairs. And also I was keen to see if there was a lift, So when somebody talks about disability, that's the first thing that comes into mind. And also in terms of either somebody is deaf, somebody is blind, but we tend to leave out people with intellectual disabilities. And I would say, looking at the statistics globally, they are the type of disability that is often left out, because people tend to feel, no, they are not able to communicate, they are not able to consent, they are not able to comprehend. So a few months back, we were discussing on how to conduct a survey on persons with disabilities. And specifically, we were looking at access to family planning. And then one of the questions was in the what is it? In the questionnaire was, is this person able to consent? And then the note for their interviewers was, if this person is not able to say yes, end end the conversation.
Yeah.
But at the back of my mind was we have somebody who has an intellectual disability, comes for this service. Probably most of the time it is coerced because either she has a child or she's being raped. So the mother says, no, let's take her for family planning for her not to get pregnant. So if we have that question, that means either the caregiver will say yes or she's not able to say yes. But from my end, I feel like if we could package the language in a simpler way, they're able to comprehend. Because you come to me as somebody with an intellectual disability and you have the medical terms, probably I didn't go to school, probably I have never I even don't know what is rape, So you really have to simplify the language for me to be able to understand this is what you mean. This is how I should be able to protect myself. This is what consent means. And as I said, looking at the disability, the intellectual disability is often really left out. And I'll also look at because I'm Kenyan, some of the policies within Kenya, they will always talk about 30% of the procurement should go to people with disability, but it never targets persons with intellectual disability. So they tend to be left out when we talk about
So even like disability or persons with disability is treated as like one monolith or a homogeneous group, not thinking about, the various ways in which people, may have their abilities impaired and what does that actually look like.
Yeah.
I think what you're saying, I have one question, which is, so obviously there are like different barriers which are linked to different types of disabilities that you have. Can you maybe speak a little bit about some of the normative or norm related barriers that you see, some of the stereotypes that you see, like especially I think when it comes to like sexual and reproductive health, one of the most common stereotypes or normative barriers I've seen people talk about is this assumption that if someone is a person with disability, they're asexual. Why do they need family planning? Why do they need to know what sexual reproductive health, right? Which is like really diminishing that person's entire being to like that one disability, which may not even have anything to do with their sexual ambitions, for instance. So yeah, I mean, if you would talk a little bit about what are some of the stereotypes that you see, because people don't often talk about what stereotypes and norms are there.
Okay. So particularly for norms, I think differs both at national and local contexts. So looking at the African context, as you said, most people assume why do they need it? And the saddest thing, sometimes it comes from the healthcare provider side and the parents. Yeah. So you have somebody with disability go for STI screening or STI treatment. And the first question they ask you, you're in a wheelchair, what time do you have to have sex? And without putting a point back in the mind is that probably it was sexual violence. Probably it was rape. Probably she didn't consent, or she consented and she didn't know she's supposed to use condoms. They're supposed to go for HIV testing before. So we have seen. I have seen actually healthcare providers have an attitude like, there are people with disability, they should not be having sex, they should not be in a relationship. In some communities, I remember back in the day, I think it was in Tanzania, where people believed if you have sex with an albino, then you're cured with HIV. So they'll, so we have so many norms, I think, and it varies from one community to another. But I would say it mostly held by healthcare providers and also the community members. So when you try and challenge those norms, and we do appreciate that healthcare providers come from our community. They are influenced by the community they were raised. So trying to change that perception or that upbringing takes time. So it does not mean that when you target them with, these are some of the norms or that may hinder people with disability from accessing services. We do acknowledge that they come from a community. It takes time. It may not be seen tomorrow, but with time, progressively, we are going to be to see at least a little bit of a shift.
Yeah.
Yeah.
A little bit of a shift, because they are the first entry point.
Yeah.
And if my entry point is a healthcare provider or a community health worker or promoters, Kenyans call them, and there's already that barrier, there's no way I'm accessing it.
Yeah.
Even at the household level, if my mom has a perception that I should not be having sex, she's locking me in the house, because it's shameful for people to see me. So that means either an uncle will abuse me, my dad will abuse me, my brother will abuse me. And if I'm abused in the house, she says, no, this is a family matter. Let's not bring shame to the family. So if that supportive environment lacks at the household level, then of course I won't get it at the healthcare facility. I won't get it at school.
I'm quite curious. You've touched a bit on some of those interventions to address some of the normative barriers on the health provider side, as well as the parent or household side. Could you just share from your experience as you've been working on this, what you've seen as some of the ways or tools that are being used at both of these levels? And I know it takes a while to change normative barriers. Of those tools, are there any that you've seen, stories that you can share where there's been a shift and things are changing?
Yeah, we have a number of tools, and I think they also differ from organization to organization. So I will talk about the ones that I'm very familiar with.
Yes.
Yeah. So at my former workplace, because their role around gender is very strong. I think globally that is their niche, and they do have a lot of tools to challenge the norms. So these are tools that are very participatory. So people come in and discuss, not in a formal way, but more of trying to reflect and see these are norms that we should change. And let's say they're very interactive tools. And I remember one time when we were looking at those tools, and specific for disability, what really worked is bringing on board organizations of persons with disability, because they have representations. So they get to share their experiences, they get to lead the discussion. And these organizations are not external organizations. They are people that the communities are familiar with. So you get to invite parents from households that have children with disability. You get to invite the larger community. You get to invite gatekeepers. You get to invite healthcare providers. So as they come, the conversation is led by a person with disability. So they sit back, reflect. If the norm is a problem to them, and as they're doing the reflection, of course, it's backed up with data and statistics on how is the progress, and maybe who are the most people, which category of population has come for antenatal services more, what are the post antenatal services that are accessed, who are coming. So the healthcare providers have that data. So as they're presenting, the person with disability leads the conversation, the community tends to reflect. And as they reflect, they're doing fun activities. So it could probably doing a problem tree. They're trying to say, oh, it's a problem, so what do we do? So the things that they write as what they do, so those forms as part of the action plans. So it's purely community-led. So an external person like myself does not come and say, oh, you need to do this and this, because I don't come from that community. This is a community-led conversation. They have their own solutions. They have their own people that can champion for solutions. So those are some of the tools that we have seen really work in getting the community to lead the conversation. As you take a back step, they get to sit, reflect, converse, disagree, agree. But at the end of the day, is for them to come to a consensus and say, we need to solve this problem. And how we are solving it is that probably we are targeting a certain household that does this and this. I know of a certain household that locks the child in the house, and also bringing on board adolescents with disability who can converse with their mothers, because mothers tend to be part of the influences. Yeah. And working from an adolescent SRHR program, the other influencer is peers. So my first contact would be somebody who's my age. So getting also to bring those peers on board and to have the very, very uncomfortable discussions about, sex. And one of those discussions or intergenerational dialogues is that the girls told a certain girl who had a disability, and the mother was very concerned, like, why do you keep getting pregnant? What is it? And the child told the mom, if you had provided me with pads, probably I wouldn't go and have sex with an uncle for him to give me 50 shillings to go and buy pads. And this is a conversation they have never had before. So we get to create a very conducive environment where they're able to have those very, very, I would say, sensitive discussions, agree, and the mom tends to reflect, probably I should have done better. And the adolescent also says, probably I should have gone to my mom to ask for this, Yeah. So,
yeah. That's interesting. The intergenerational dialogues, them leading their conversations. I think it's something we've had previously before on this podcast. But I'll follow up on the other side, the community health promoters or the health centers or healthcare providers side. What are then the tools that we are employing for them? Is it still similar? Or how we changing those norms and perceptions on that side?
So for healthcare providers, as many people know, especially for healthcare providers who are in a public setting, they get to say, oh, our workload is so big. So they wouldn't come for those community sessions. So what we felt would work for them is having sessions during their CMEs. So CMEs is continuous medical education. So, and they are done, in most facilities, they are done monthly or weekly. So during those sessions, in the morning before they start their day, they are taken through some of the norms that they hold as healthcare providers, because they're also trying to see why are the people with disability not coming for services. So probably it's on our end. So same approach, we get to have either a community health promoter who's a gender champion to lead that conversation. And what I've seen work is to have a male gender champion. Not because not because they are, they have some certain view, but because this is somebody who's already an ally to gender equality. So they get to lead those conversations. We get to have a healthcare provider who's a gender champion, who has also been trained through SRHR. They have gone through several trainings and being capacity built on the need to why, ensure they are creating a conducive environment. So during the CMEs, they have those discussions. They get to reflect. They get to say, oh, do we need to do this? Do we need to do that? And also another thing that I've seen work is a tool that is called the community scorecard. So the community scorecard is more of an accountability tool that it's used to, hold the leaders or, leaders, I'd say.
I mean, the community leaders?
Not really.
Okay.
So, specific in the SRHR space, the leaders for us will be the Ministry of Health, the healthcare providers. I have forgotten the term we use, but more of the ones that hold power, the power holders. Yeah.
Okay.
The power holders. So, so during the community scorecard, we also segment them according to their categories. So we have healthcare providers sit down separately and reflect, why are people not coming for services? So if it's specific for people with disabilities, why are people with disability not coming for services? Is it that our facility is not accessible? Is it that in terms of physical accessibility, is it communication? Is it our attitude? Is it the norms that we hold? So they get to reflect and come up with an action plan. So within 3 months, we'll ensure we have a RAM. We will ensure we have sign language interpreters. We will ensure we have posters for visual like very good posters. We'll ensure we have drawings that communicate. So if I'm somebody with an intellectual disability, I'll see probably a young girl in a wheelchair trying to converse with a healthcare provider. So the posters really communicate and send a message. So they get to do that. And this community scorecard is reviewed within a period of, let's say, 6 months. So they come back again and see how is the progress, what is the gap, who needs to come in and support us do that. So specific for adolescents programs, the community scorecard is usually adolescent-led. So the adolescents lead the conversation. So as they come to do the follow-ups, they're able to hold the power holders, in this case, the healthcare providers, accountable. Like you said, in 3 months, you're going to have a RAM. So where is the RAM? You're going to have, the toilets will have handrails. Where are they? You're going to train people on sign language. How many have you trained? And if there's no progress, then what is it? Is it budget? Is it, like lack of the buy-in from the healthcare providers? And what do we do? Do we bring on board people who allocate budgets? Do we start looking for organizations to support that? So that is part of what we do with healthcare providers.
At what level is this happening? Is it like health facility or county?
No. At the lowest level.
Okay.
So we look at, let's say, in a sub-county, how many facilities are there. So it's very facility specific, because you'll find one facility is very progressive and the other one is really doing bad. So the action points are specific to the facility. But the beauty of the community scorecard is you also get to invite people in power, like if the governor is available, if, let's say, somebody who can influence, especially issues around resources. So they get to come and see, oh yeah, we really need to do this and this. Yeah.
Have you seen so I'm just trying to imagine a situation where there's an adolescent trying to hold, someone in power accountable. It feels like a very empowering situation, very inspiring situation. Are there examples of changes that you've seen through this process? If you could talk about, is there a facility in the sub-county that, did not have X, but then ended up having it because of this process? What are some of the changes you've seen on the ground?
Yeah, we have seen, because I have implemented the community scorecard in Nairobi, Kajiado, and Kisumu. So specific to, let me give an example of Kisumu. There's a sub-county called Kisumu West, and at the beginning, I think it was the issue was more of attitude, because adolescents are not coming to facilities because healthcare providers have attitudes. And now you can imagine this is an adolescent girl without a disability. But for the ones with disability, they'll say, no, I don't understand what she says. Or probably I go and she assumes I want this method, I want pills. And I don't want pills. I want them to discuss and give me the options for me to choose for myself. So they did go through the community scorecard, have those discussions, and progressively, the last time I was with Kara, we did a survey that was in December, and we'll see some gradual shifts in healthcare provider attitude. They'll say, at least they're trying, because we couldn't actually define what adolescents mean by attitude. And during the survey, we got to discover that a simple thing as touching your phone means attitude to them, because you're not paying attention to them. So they'll tell you, no, she's always on her phone. So I wouldn't go to the health facility, because the health facility side will say, no, they have been trained. We even have young people as the ones welcoming them. We have a youth center. So we have really worked on the attitude. So we don't understand what they mean by attitude. But the simple thing as, holding my phone during a conversation means an attitude to an adolescent, and during that really opened the healthcare providers' eyes, and they're like, oh yeah, I need to concentrate. I need to give my attention. Yeah, I need to lock the door when an adolescent walks in, I don't need to shout. They don't be put in a space where there's a grandmother, 40-year-old, my neighbor. I want to stay alone with them. And they also don't want an old person to serve them. And others were like, I don't want a young person to serve me. So,
Wow.
so it depends, yeah. But we've really seen a lot of shifts. We've seen, health facilities have handrails in the toilets, have a ram, because others would have a ram and lock that door. So I'll still need to use the stairs or somebody to carry me. A simple thing like having an adjustable examination bed. So if the bed can be really adjusted to the level I'm able to access the bed, I don't need somebody to raise me. And sometimes it's a male healthcare provider. So if they raise me, I feel, oh God, they'll probably touch me in a place I don't want to be touched. So yeah, it's like progresses. Mm-hmm.
And what about, so this is like obviously at a facility micro level, but these are such big systemic issues, like things like budgeting, things like if there isn't easy access for the facility to have adjustable beds, right? So there is like a policy, institutional angle to it. Could you maybe talk about, what are some of the policies that you see that need to be changed, or do you see any movements or trends in the policy landscape, like Kenya or otherwise, to be more accommodating?
I always say I like the policy that it was adopted in 2006, the Convention of Rights of Persons with Disabilities, and progressively we have seen so many countries really ratify the convention. But the sad thing is most policies don't put in place or try to have laws and regulations that are in line with the convention. Or sometimes they do and they don't implement it. So, for example, the convention does say it's a right for all people with disability to access SRHR services. But looking at the SRHR policy in Kenya, then it has its own, let's say, policy lines. Yeah, because of course, the Constitution guarantees, the 2010 Constitution guarantees that everyone has the right to access SRHR services, but the policy and the Ministry of Health policy and the educational policy do not marry. Because if you go to the healthcare facilities, then a healthcare provider will tell you, I cannot offer services to a 15-year-old girl because the policy does not allow me. But again, this is a 15-year-old girl who, by the time she comes to access the service, sees the need. She's probably having unprotected sex. She has been pregnant. She's probably she probably has multiple partners, so she needs something or SRHR services to ensure she's safe. And these policies sometimes really do crash. And currently, I know CSOs did go to court to challenge the Ministry of Health SRHR policy because it was not guaranteeing adolescents below the age of 18 to access SRHR. And looking at statistics, that's the cohort that is getting pregnant. That's the cohort that is getting HIV. So if you're telling me I'm not able to access family planning, I'm not able to access STI, I'm not able to access abortion without consent from my parent, then I'm not going to come because the issue is consent. My parent has to consent for me to get.
So that's what the
family
policy
planning.
says. If you're under 18 to access any services, you need parental permission, or your
Yes.
parent needs to come with you.
Yes. The parent needs to come. And probably my parent does not know I'm having sex. And I honestly don't see the business why she should know. And I always tell people, I know it gets really bad eyes when I talk about this. If I'm assuming I am a parent to a 14-year-old, the best thing I can do as a parent is to give the information. And for my role is to give accurate information.
Yeah.
Talk to me about family planning. Talk to me about the methods. Talk to me where I need to go to get these services. Because if you don't, then I'll go to my peer, and probably my peer has no information. So
Or like wrong, false information.
Yeah. And she give me wrong information. So the role as a parent is to give me accurate information. Create a safe space that I can be able to communicate to you freely. Then if I'm able to go to the health facility, then I'm given the available options. The healthcare provider does not look at me and say, let me give you injectables. She's able to give me the options that are available. Take me through, give me comprehensive information. Like, these are the side effects, these are the effects, or these are the advantages. This is how your body will change. This is what you should do in case your body changes. Come back for appointment. That's the basic information you can give me. And then let me make an informed choice and get the service that I need. So the current policy in Kenya on SRH specifically requires consent for below 18, but we have emancipated minors. I know they have a clause around an emancipated minor can come and access the service without consent. But if I'm able to get, if a healthcare provider is able to let me consent in terms of surgery, why can't I consent when it comes to family planning?
And what is an emancipated minor?
So an emancipated minor is a minor who people say, how do I define it? A minor who's, due to circumstances, can be able to give consent without the parents' consent. So probably I'm a 16-year-old who's married, so I'm an emancipated minor. I have a child. I have the right to say yes to any service that I want. Yeah.
As we look towards the future, what areas do you think still need more attention from the various stakeholders?
I would say working closely with women-led organizations with disability, because they don't get to sit in those spaces and discuss issues. Because and we were doing a mapping of organizations of persons with disability, and they were not led by women. They were led by men, and they're in the SRHR space. It's okay. Men are allies. They're allies and they're championing for those rights. But I feel if women-led organizations with disability could be brought on board to share the experiences, to share their perspectives, and it's also a way of building agency. They get to build the agency of the young girl with a disability back in the village who's not able to voice. So their voices are heard, their voices are put in place. And another thing that is really needs to be given more attention is issues around data. So looking at the data information systems that we have globally, we don't have a system that collects disability-specific data. And this does not inform programs whether we are making progress or not, because we are not able to track how many women with disabilities are able to access SRHR services. What is the loophole? What needs to be done? I know some SDGs have the indicators on data, and specific, the one that is on health lacks that. So we really need to work on how do we collect disability-specific data. Yeah, because most of the time you get the tools are either male or female.
Yeah.
So we don't collect the disability data. But again, looking at how most programs really don't pay attention on issues around financing for disability. So disability is always an afterthought. After implementation, like, oh no, we left out people with disability. So we go back again and try to bring them on board. And for us to really reach out to people with disabilities, there's a need for us to really make it deliberate and intentional to include them all through the process. So have them in mind as we program, as we design programs, all through the stages, and let them really have input at the design stage, at the implementation stage, when you're doing monitoring, when you're closing out, through all the whole process. Ensure you are collecting voices of people with disability. I'll say those are the really areas that really need to be put in place, apart from the obvious one, which is policies. But I feel like we really have so many policies, very beautiful policies, but where we drop the line is implementation. So for example, we have beautiful policies around disability, around gender, but when it comes to implementation, then you're like, oh, God. Yeah.
Pretty on the shelf.
Yeah. Yeah. So, but looking at financing, working with them, collecting data, and also I know the recently concluded Global Disability Summit one of the key things that was pointed out is lack of data. And I remember one of the WHO representatives coming in and saying, "Oh, we are trying to do a guidance notes to work closely with organizations that do disability inclusion, just to see on how data is collected." And that's a good move. And if we can have that adopted across all countries, then that will really help us understand how far are we. And one of the panelists talked about how disability is 10 years behind gender. So by the time we are accomplishing gender equality, then we will need 10 more years to ensure we are accomplishing issues around disability.
And gender equality is like 250 years to more.
So that's a lot of time. That's a lot of time. So as we talk about women, we have women with disability, we have girls with disability. So where do we leave them? They'll feel like they are enjoying their rights 10 years after we've achieved gender equality.
So Nyasani, before we wrap up, or as we sort of wrap up, maybe what is your one call to action to people listening here? Like, who could be, healthcare providers, people like us, or people who are learning for the first time about, disability and sexual reproductive health. What's the one thing anyone can do very tangibly to make sure that, we're thinking about gender and disability inclusion in sexual reproductive health? Like, what would be a call to action?
My call to action would be bringing them on board. First step, because if we don't bring them on board, there's no way we are going to include them in other areas. So as we design programs, as we design interventions, at the first point, the same way we consult with women is the same way we consult with people with disabilities. And another call to action is we were looking at globally, 15% of the population are people with disability. So my call would be 15 for the 15. So ensure everything we do, we have 15% allocated for people with disability, be it jobs, be it at the workplace. So 15% of the employees should be people with disability, to the least, to the minimum, because that's their percentage globally. So ensure we are putting in place 15 for the 15. Yeah.
That's a great note to end today's conversation at. So thank you so much.
Thank you for having me.
Nyasani. This was very enlightening.
Yeah, thank you so much. And it was a lovely conversation. If you enjoyed it, please make sure you share, subscribe, follow, hit all the multiple buttons that are there on your screen, and join us next time as we continue exploring various issues of gender equality. Until then, keep pushing for change.
Thank you.
Thank you so much.